And before we get started, since I am a behavioral health provider, I like to just do my internal check before I meet with patients or clients about what's going on with me, so that I can approach them pretty clean without my own baggage coming in. So here's some questions that you might ask yourself when you're dealing with a patient with overweight or obesity. What are your beliefs and discomforts around patients experiencing overweight and obesity? You know, some people can have really strong opinions about what it means to be overweight. What is the best way to value their autonomy and decisions around their health issues? And how do your values, religion, education impact your work with this population? And I'd like to say I'm not going to give any answers for this. These are personal questions, and they're not right or wrong answers. It's really just being introspective and understanding where you come from when you meet these patients. I'd also like to say, because this is a back to basics presentation, that a lot of this material I have presented over time in the last few sessions, maybe the last 3 or 4, and then just kind of brought it back together to think about what are the important parts we could think about and work on over the summer. So before I really start talking about what MI is, I would like to just kind of lay out, I didn't make a slide for this, and I probably should have, but the guiding principles about motivational interviewing, just things for us to think about that are really important and foundational. And that an important guiding principle is to resist arguing and persuading. It's easy to get into the habit of persuading, particularly behavioral health providers want to do that thing where I want to tell you why it would be better to go down this road than another, and let's resist that when we're using motivational interviewing. The second guiding principle is to understand your patients, their motivations, their values, and what's important to them. The third guiding principle is about listening. In motivational interviewing, you do more listening than talking, and listen with empathy. And then lastly, we want to empower our patients, and we can do that by believing in their ability to change. Maybe not on our timeline, but in their ability to change. So when we're talking about what MI is, it's a person-centered approach. It's really about the patient, meeting them where they're at, understanding their needs, their values, their concerns. It's collaborative, meaning it's an invitation. We're going to work together to solve this problem. Evocative, to evoke. How do we do this? By listening more than talking, by eliciting rather than advising. I really want to understand from you rather than advise you about what to do. I want to elicit what you think you might be able to do. Responsibility for change belongs to the patient and client. It's hard, I think, sometimes as healthcare providers, we want to help people change and feel better and lower their blood sugar or lower their cholesterol. And until they're ready, until we can find out what it is that motivates them to make that change, it's up to them. And we're going to make the space for them. Unless we have a very urgent or emergent situation in their health, we're going to let them take their time to figure out how to make the change. And it's respectful. We're going to honor their autonomy, their resourcefulness, and their ability to choose the path to make the change. I pulled this slide and these things right out of Bill Miller and Stephen Rollnick's book in 2008, because I think it's important for us to remember what MI is not. And it's not based on the trans-theoretical model of change. But what I want to say about that is that model gives us places to understand where people are in their thought process about making change. And there's some, like in the pre-contemplative stage, that's a really good place to use MI, because they're really thinking, they're starting to think about that change. How might we help them discover the motivation to make the change? It's not a way of tricking people to get them to do what you want them to do. We're not going to try to figure out what the motivation is and then make a deal with them and get them to go down that road. It's not a specific technique. I really think of MI as a communication style. It's not a form of cognitive behavioral therapy, and it's not just client-centered. And I appreciate all that client-centered learning I got in graduate school and about Carole Rogers. And MI is a little more directive. we arrange conversations so that we can get the clients where we need to go by practicing the skills we learn along the way about using motivational interviewing, the kinds of questions we ask. And it's not easy to learn. I've been working on this for several years. I would still say I'm at the basic expert level. I mean, I can push myself up a little time when needed, but you have to practice it in the clinic. And now that I do program management and whatnot in Envision, I don't have the opportunity to be in the clinic and keep practicing so that I can build my skills to the next level. It's not what you're already doing, and while I put that there because many people have an empathic communication style. They listen more than they talk. They really seek to understand, and just because you do that does not make it motivational interviewing. There's a few things that you would add to make it motivational interviewing. So I would say people that are more empathic and more listeners than talkers are probably a little more ahead of the game in using their motivational interviewing. And just remember, MI is not the panacea for every clinical challenge. And in fact, there are studies out there about where it works the best. And that is around health behavior challenges, around beginning or maintaining healthy habits, around giving up or minimizing adverse behaviors, and around adhering to medical advice. These are opportunities to use your motivational interviewing skills to work on goals that are driven by the patient to up their exercise or lower their alcohol intake. And we can talk about some of those strategies as we go along. Now, every now and then I realize I speak really fast when I'm doing presentations, and if that's the case, give me Dr. Coloring can give me a flag, or somebody could say, could you say that again or slow down? Feel free.
Or I could mute you.
You could mute me, and then we'll just let Dan finish.
Yeah.
He's like, An important piece of motivational interviewing is thinking about ambivalence. About that, well, I could take it or leave it. I'm on the fence. I'm not sure which way I want to go. Recognize that it can be indecision. They're not sure how they would even do it. Perhaps it's insecurity. When we talk, I hear this a lot with students or new practitioners of social work, where they will talk about the client is so resistant, and it might be beneficial to ask ourselves, are they resistant or are they ambivalent? Could I help them explore what their concerns are about making the change? If, when you're in a discussion with a patient or client and you argue for one side of, I need you to do this, I need you to quit drinking, the ambivalent person's going to defend the other. Well, that's how I relieve my stress. And 2 glasses of wine at night after dinner isn't going to cause any problems in my family. I mean, you can hear it because I've made that space where there's nowhere really for them to go except for to defend themselves. So part of the strategy in motivational interviewing is to not take up that side of the argument. As a person defends their status quo, the likelihood of change decreases. I mean, they're going to dig their heels in and hold on to their piece of the argument and resist the urge to take up the good side. It's okay to ask questions about the behavior of the person, like smoking. What is it about smoking that helps you relax? Or what is it that you enjoy? I mean, just don't be afraid to ask those questions, because in that you'll get some discovery. Are you thinking something? No? And I'm asking that to a person here around the table who's looking at me that I thought had a brilliant idea. Okay, and so when we're working with ambivalence, here's some things to keep in mind, is that patients are not often aware of the conflicts where they say, gosh, I would really, really love to lose 20 pounds, but I just love having my big gulp every day on the way home from work. Not seeing where those things might contradict each other. When you're working with ambivalence, remember that it's not your job to hand the patient the solution. In fact, The more the solutions can be generated by the patient, the more likelihood they'll engage in the change, because the motivation, the solution is perceived to have come from self, right? So if I can come up with this idea, I can probably do this idea, and I've bought into the idea. Working with ambivalence is a way to begin to mirror what you hear. I'm noticing that you say you would like to lose 20 pounds, and at the same time, you've told me you would not like to give up your big gulps after work. Tell me about that. How is that going to work for you? Do you have some ideas? What would you give up instead of the big gulp? That's a place to explore. I want to remind you, too, that it can be difficult and somewhat uncomfortable to hold the patient's ambivalence, because it sounds like they're maybe going around in circles and they're talking themselves out of, both sides of the mouth, to use that expression. And if we can just sit and be patient and let them work through, all of a sudden they start to hear their own solution. When we're working with ambivalence and we're just asking them to tell more about their concerns about going one way or another, I think it's important to use what I call the weatherman voice, where it's just real calm and even. You're not showing your concern about that behavior that might be, really disturbing to us as healthcare providers. You're just really calm, and tell me more about that. Like, really? You're smoking 2 packs a day? Would you tell me more about that? And it sounds so like you're really rattled, but, so your habit is 2 packs a day. Let's talk about that. There's just that evenness. In motivational interviewing, it's important, if we are going to make some movement in a short visit, to really think about our target behavior. What is a target behavior? And it's one that you want to increase or decrease in your patient's behavior. I would like them to increase exercise. I would like them to decrease alcohol consumption. Whatever it's going to be, think about it very specifically. You do want your target behavior to be clearly defined, and that helps you kind of anchor the focus and the direction in the visit, so that your questions, when you get to the open-ended questions part, can really be directing them down a certain path to thinking about ways of change. It is often the case when a patient comes to us that our goals aren't really the same from what they want out of the visit. And we think about ambivalence or the target behavior. This really gives us an opportunity to negotiate the talk. So I hear that it's really important for you to talk about, like let's say with a teenager, your acne. So if you talk about that, would it be all right with you if I spent 10 or 15 minutes talking about your smoking or your marijuana use? And so then it's perceived that what is important to them is important to you, but they also hear that you have a message for them that you might need to relay. So we're going to just kind of negotiate that talk, get some buy-in. So we're having discussions. Patients are telling us about, their behaviors, their concerns. We're really listening to understand and to focus on our target behavior. But really what we want to do in that 15, 20 minutes is get to the place that we can hear our patient communicate some change talk. Common dimensions, change talk. Dan gave us this one beautifully, was the darn commitments. And that was over a year ago. You might have forgotten, Dr. Dan, but you were the one, you're like, those darn commitments. So that's the acronym. I don't know if any of you have been exposed to MI out there. You know that it's big on acronyms. And this is just another one, darn commitments. So change talk, these are dimensions of the desire, the ability, the reason, the need, and then commitment. There are very specific ways a patient could tell us that they're committed to making the change. And so let's talk more about those. The desire is what the patient wants or doesn't want to have happen. An ability is what they believe they can or can't do. A reason is the why or the why not. I want to feel better. I want to look better. I wouldn't wear size 6. Whatever it is, those are their reasons. And the need, what they think they need or don't need to do. You know, I really don't need to be smoking 2 packs of cigarettes a day. And then commitment talks about thinking about where they are in the future when they're thinking about change. I think I could exercise 20 minutes every day. I'm going to exercise 20 minutes every day. There you've got some commitment, so hold on to that. Write it down in your little plan about what our negotiated goals are. Wait, before we move on, I was thinking there's some ways to ask questions to get at this in the visit. Again, this comes back to where MI is evocative, where we're really pulling from the patient. So desire, why would you want to make this change? Or ability, how might you go about reducing your soda consumption in order to succeed? Reasons, you can even ask, what would be the 3 best reasons for you to quit smoking? Need, how important it is. How important is it for you to make this change? What might happen if you don't make the change? And out of that, you will get a need. People will say, well, if I didn't make this change, I might not be able to do A, B, or C. So I really need to think about, or you know, I might not be able to live in the fraternity house because it's non-smoking. I mean, it can be, what, you know, whatever example. The commitments. What do you think you'll do to have this happen? What do you think's in your control to change? What about, you know, like if we're looking at the 50-50 plate, what could you add to your 50-50 plate today, and are you willing to do so? Yes, I think I'll work on my 50-50 plate this week. I mean, I'm simplifying. It takes a little longer than that, but that's the road you would go down to negotiate those changes. When we start talking about making the change and listening for change talk, that's where we get to a place that resistance shows itself. Well, that may be a little too fast for me, would be an example. And so some things I think about with resistance is that it's energy. So we can use it to help the client move forward. Oh, that might be a little fast. Okay, so what sounds like more reasonable goal for you to achieve? I mean, right there, we've turned the conversation back around. Opposing resistance generally strengthens it, so don't push. Okay, you're telling me you're not ready. What else can we talk about today? By doing that, you leave the door open to have further conversations because they felt like they were heard, and this isn't the thing that was important to them right now, so I'm just going to leave the door open. If resistance increases, change what you're doing, the questions you're at. That's right there is a sign to you that you're on the wrong track, and then we need to shift the road we're going down because they just get more and more defensive. I mean, you can often think of resistance as a form of defensiveness. So offer new perceptions, but don't impose or argue them. And then you don't feel like you have to answer their objection or their resistance. It's not. We don't have to speak to it. We could kind of let it roll. Meaning, are you wondering about that?
I'm still wondering about offer new perceptions.
About the resistance.
So is that implying that if you notice the resistance is increasing, then kind of go back and offer a different
way of looking at it?
Yeah.
Or,
okay.
You know, oftentimes people will tell you they want to talk about A and B, and so you could just say, well, right now let's talk about, to just kind of.
Okay.
Can you read my sign language?
Along those lines, the word perspective came to mind for me.
That's
offering new perspective
on the condition or whatever it is we're talking about. That's a great idea. So if we were talking about, you know, the teenager reducing marijuana use, just for example, that we're concerned about that. And no, I need that because I have anxiety and all my friends do that. And how would we, because I've never practiced it from that angle, Dan, how would we offer a new perspective? I mean, do you have and not to put you on the spot, but I'm just thinking, how would we turn that around as a new perspective? That'd be something just for me to play with and think about, but.
Risks associated with use. and balancing those risks with the perceived benefits
Yeah.
of the use.
Yeah,
Because it's the
okay.
adolescent perceiving that they're using.
Right,
They perceive the benefits.
right.
And, but I think the perceptions are valuable as well, because it would be comparing the youth's benefits
Mhm.
of how he or she experiences cannabis as useful to them, compared to others who observe, oh, you seem like you're out of it, it's really hard to communicate with you, you'll talk about being able to focus, but we'll notice you being distracted.
Those are great examples, and I like that perspective. I'll add that the next time I do the back to basics. No, I think that's a good. Then we don't get stuck in just, the one perception piece, and we can really offer a whole other perspective that might be helpful. Any more questions around resistance? Resistance is futile? So signs of readiness to change. How would we know? How would we recognize? And this can happen in a pretty brief visit, 15, 20 minutes. We have a good conversation. These could happen. We could recognize some readiness to change by perhaps decreased resistance. All of a sudden, they don't seem as defensive. They're open to some suggestions. They have their own ideas about how they might make a change. They have fewer questions about their problem. And this is an interesting one, because it can often feel at the beginning they're overwhelmed, say, they've had this diagnosis, or they're having a challenge or a problem, and they have so many questions. The questioning goes down because they're starting to understand what the problem is, and that there's probably a path for them to get out of it. So they're asking fewer questions. The resolve or the resolutions. I know I can beat this, and starting tomorrow I'm going to do A, B, or C. They're ready. You know that they're getting ready to change. They make self-motivational statements. And then they have increased questions about change. So if after a month I've exercised, regularly 20 minutes a day, 20 minutes 4 times a week, and I've cut out my sodas, do you think you would notice in my BMI, or do you think you would notice in my cholesterol? They'll start asking questions about what that change might look like for them. I imagine myself successfully going to the gym, and then I start experimenting with things. I went to the gym. I didn't really like that. I prefer to walk with my neighbor and walk our dogs around the park. And they share those things with you, and there's movement towards change. A tool, excuse me. Okay. So, a tool we use, the ruler. The Assessing Readiness to Change ruler. On a scale of 1 to 0, 1 to 0. I was really bad at fractions in high school. Okay, here we go again. On a scale of 0 to 10, how important is it for you to make this change? On a scale of 0 to 10, how confident are you that you could make this change, quit smoking, whatever the change might be? Now, I want to point out a couple of things about MI. It's very important to use 0 and not 1 as our starting point, because 1 implies you're kind of ready to change. Not that ready, but there's some thinking about it. 0 is nada, nothing, zip. That means I am no way interested in what you have to say about the change. Now, with this ruler are some ways that you can get a little information when I'm talking about importance. So, why are you at a 4 and not a 0? And listen to what they have to say. Well, I'd like to make a little bit of a change, but I'm not, this isn't the highest one on my list, so I'm only a 4. Okay, so what would I need to do to get you from a 4 to a 5? Just figuring out for them what things might be important to help move them along. Confidence is important also. We want the change to feel important for our patient or client, but we want to also understand what's their confidence level to get it done. I mean, I want to change so bad and I want to lose this 25 pounds, but I'm not confident I can do it. I have no tools. I've never been on a diet. I don't know what that looks like. So you explore that confidence with them, particularly if it's like 5 or below. And you can ask that same kind of question about what would you need to do what would need to happen to get from 5 to 6, or from even 5 to 7 in your confidence. Is it more information from me? Is it a good example of the 50-50 plate and how you might follow it? I mean, those are the opportunities to understand better what your patient might need to get ready to change. So since we've been talking about all this change stuff, we're going to play a little game, and it's called Drumming for Change Talk. How we do this is, these are statements from clients who the change target is improved glycemic control. That's what we want for these patients. Here are the component behaviors: diet, exercise, medication, monitoring, stress management. All of those things are pretty important. So we're having a conversation. So how this game is going to go is I'm going to read a statement such as, I think I'm doing about as well as I can at this point. And then the audience decides, is that change talk based on one of those components we learned about: desire, ability, reason, need, commitment? Or is it just resistance? If it's resistance, no drumming on the table. So let's try this with a few. We're going to practice, and if you recognize it as resistance, you can say resistance. Just don't drum on the table, because that lets me know that you know it's change talk. Are we ready? Are you ready, Dr. Conley?
I'm not sure. Yes.
You are, Dr.
This is
Dan.
audience participation.
Yes. So you feel free to unmute and jump in. Do you have a question, Dr. Dan?
I'm not sure.
Okay.
That's what I said.
Are you ambivalent?
Kind of.
Okay. But let's play anyway.
No, actually, I wanted to be clear. Is the expectation of the participants that it either is or is not change talk? Because there are some ways, well, if I may just say about this first example, or I guess since this is motivational interviewing, would it be okay with you if I use this example for my question?
Yes, I am confident, Dr. Dan, that you're going to have a great question.
Well, the example you just used could be interpreted or thought to be resistance, because the person is saying what they can't do. However, it could demonstrate their ability, their belief in what they can or can't do.
I think I'm doing about as well as I can.
Like doing about as well as I can. They may have achieved a lot to get there and maybe on their own personal plateau and saying, you know, for right now, I've made some changes, I'm good.
So, I wonder then if they're thinking about changing anymore. Because they're just saying, I'm doing about as well as I can here. So, I think you're right that
They may have just, again, made change.
Right. So, let's not assume about where they were before they made these statements. That'll make it a little easier, then I won't be as confused.
Although that statement could also be ambivalent. I think
Yes.
I'm doing as well as I can.
Yes.
But I don't know for sure.
But since we're going to practice change talk, let's not confuse it with ambivalence.
Okay, sorry.
Okay, that's okay.
So they may have just made, not after making change, they could be pre-contemplative for their next change.
Yes, yes. That's a good point. So since that one's confusing, I'm just going to take it out for the next time I play this game.
Well, I think it's a good example for the purposes just described.
Let's do a few around the table.
Okay. So we'll
Okay.
start with a couple around the table, and then we're going to ask the people out in the audience to do a round.
That'd be great. This actually can be fun. Okay, so first comment. I certainly don't want to go blind. Okay, so the change talk piece in that, they're giving you a reason. I'm open to change because I don't want to go blind. Does that make sense?
Yeah, I can't remember what the drum roll is for.
You drum when you hear the change talk.
Oh, okay.
Or because you have a secret desire to be in a band. Okay. I really hate pricking my finger. That's just a blanket statement. They're just letting you know they've got a little bit of discomfort about what's happening moving forward. Okay. You know, I wouldn't mind cutting down on stress in my life. Good. Which part of change talk?
Which part?
Desire.
Oh, desire.
Yes. Yes. Just think your darns.
Yeah.
You know, desire, ability, reason, need, and then a commitment. Okay. Wow, I probably could exercise more. What do you think?
Ability.
Yes, ability, yes. Yes. I used to exercise regularly. Nope. Just a statement letting you know. Just letting you know. I would say that's an opportunity to, let's talk about that a little more. What did you used to do for exercise? How might you add a little bit of that in? You know, you can grab onto that opportunity. Okay. I have got to get my blood sugar under control. Yes. And
Need.
yes. Yes. So, should we open it up to the audience?
Yes.
Do we have some, are you guys game out there to play a little drumming for change talk?
Sounds good.
Okay, thank
What's
you.
their drum roll
Sure.
equivalent going to be?
Well, if they
Yeah.
drum roll on their desk, we'll hear them, right, Kevin?
We should.
Be sure to unmute
Drum
your
loud.
phone.
Drum loud, RIT says. Okay, so let's play. I am willing to take oral medication, but I don't want to take insulin shots. Is somebody drumming out there? I think I hear it. Okay, so that, we're not sure quite if we heard it, but that is change talk, and that's commitment. And it's funny because it has the but in it, but I don't want to take insulin. But before that, they say, I am willing to take oral medication. So they're committing to, I'm going to do this. Okay, so let's try another one. I don't like watching what I eat. I mean, I guess I have to. It's just hard to feel restricted. That is change talk. Give a little more time. Okay. Feedback in the room is that to give a little more time so that I can, you have time to answer in the audience. And if you are drumming, if you'll drum a little louder, it's hard for me to hear.
And don't forget to unmute. And Kevin, unmute them,
Everyone's unmuted.
please.
Okay, so here's another one. It's pretty scary thinking about losing my feet. Yay! Yay! Yes. You want to venture a guess of what a dimension of change talk?
I'm sorry, venture a guess of what?
What element of change talk? A desire, ability, reason, or need?
Reason.
Yes. Yes. Thank you. Yes. Let's try another one. I think I'll be able to cut down on sweets. Yes, yes. And what do you think, which element for this?
Change.
Yes, it is change. Specifically, it's around their ability. I'll be able to do that. I think I can do that. They're letting you know that that's within their ability to succeed. Let's try another one. I don't think I really have diabetes. Right on. That is not change talk. In fact, that's probably not even sure they want to accept their diagnosis, and that's a whole other webinar.
See, again, I'm stuck on that one because
Okay.
Yeah.
what I would say is they would come in and say, I don't have diabetes. That's a lot more
Affirm.
firm instead of I don't think. I guess I'm on the think thing. I'm like, I think I can make them think something else.
I wonder if it would be helpful to think of resistance as having more of a continuum, and at the most severe end, it can be denial.
Right.
That sounds like a more absolute denial.
Because it just seems like there's a little bit of wiggle room when they say, I think versus I know or I do not.
So I agree that there's more wiggle room. What I would say is they're not in a place to think about change yet.
Okay.
You know, they're not giving you change talk, something you could work with to send the conversation in a different direction.
All
Does
right.
that make
Yeah,
sense?
that's helpful.
I like that continuum of resistance from denial. I'm sorry, did you want to say something out there?
At first I was confused. I thought maybe it would have fallen under ability because of what they believe or they don't want to believe or can believe. They can't or can.
Mm-hmm.
So I don't know. I guess I'm a little confused.
Well, so let's think about, does the statement, okay, so they're telling you they don't think so, and that gives us opportunity to have a meaningful conversation about really what their diagnosis is and where they're at. But I don't see in that statement the change talk in any place that they're thinking about making a change because they haven't come to terms quite with their diagnosis. So I don't think I have diabetes.
Okay.
So
No, I got you.
Okay. So, thank you for playing.
That's it?
Drumming for change talk. Well, we could do more, but I have a few more things I need to talk about.
Okay.
And
That was fun.
Do this at the end. So we're going to skip that one little slide about the brief encounter and talk first about the ORs, which is foundational communication pieces for motivational interviewing. So the ORs, once again an acronym, open-ended questions, affirm the patient's experience, what they're saying to you, reflective listening, and summarization. These are the things where you want to practice. So open-ended questions, they encourage the client to tell us, or the patient to tell us more about the topic. They can't be answered yes or no, such as, are you feeling depressed today? No. Or yeah, a little. I mean, there's no room then for them to expand and tell you more about that experience of what they're feeling. So to switch that, you would just say something like, how are you feeling today? Now they can't answer, fine. And then you're a little stuck, right? It's one word answer, so, well, tell me about fine. What is that today? You know, well, I made it to all my classes, or, you know, whatever that is, they'll expand a little more. Open-ended questions also, they function as a door opener. They invite the client to talk a little bit and not just answer your questions. And they lack judgment. I mean, I did a lot of work with teenagers, with adolescents, and, you know, I would have to ask questions about, tell me about your substance use, you know, tell me about your sexual activity. We want to keep you safe, you know, running young girls' reproductive health groups, those kinds of things. And so you just want to open it up in a non-judgmental way. And I think by not asking, by making them open questions, they're less judgmental. So then we want to affirm, a key ingredient of the motivational interviewing style. Supportive and non-judgment. It values the individuality and autonomy of the client. Effective affirmations are brief and precise. And it acknowledges the client's strengths and positive attributes. Something to keep in mind is that if they're not genuine, people know that. So don't just affirm something if it's really not okay with you that they're doing that thing or not doing that thing. Don't do the affirmation. Find something that you can genuinely affirm and appreciate about your patient or client. Does that make sense? Okay. And then reflective listening. When we start out as MI practitioners and trying to use this in our brief patient encounters or around health behavior change, we often just parrot, and I would say that's okay. That's how you start practicing, is you almost parrot back to your patient or client what they have said to you, and as you practice, you can expand your ability to reflect back and even use a little bit different words to gain a deeper understanding of what it is the patient means. Reflective listening is really, they're just small summaries of what your patient says. They're a partner of the open-ended question, and practice, practice, practice. Because you do want to move away from that kind of parroting style. I'm really not feeling that good today about, my diet. And then you say, so today you're not really feeling good about your diet. And that's an okay place to start, but you want to improve your skills that you can expand on that. And then summarize. Pulling the client's statements together, it lets them know that you've been listening all along the way. You understand what their concerns are, you understand what's important to them, you understand what they perceive their fear and limitations to be. And when we summarize, this can help elicit and perhaps get them to think more about what they want to change, make, broader statements about change. I was trying to think, there was a bouquet. That's used a lot in MI, to think about it as a bouquet, that all the little pieces, all the little things the patient has told you along the way, you just pull them together in a bouquet. And then ask, did I get all that? So that they can let you know if you didn't, and might be things you have forgotten that might be important to them, or if you didn't exactly get it right, they'll say, well, no, not exactly, and appreciate that. And then we're going to go back to,
So I'm sorry, may I ask a question?
Yes, you may.
Between affirm and reflective listening. Reflective listening is where you more kind of repeat what they said, maybe in a slightly different manner.
Yes.
But affirm is where an affirmation is where you give them some sort of credit for some action.
Yes.
Or inaction, whatever it may be. Okay.
Yes.
So you're not really saying,
That it's okay to smoke a lot of marijuana or whatever. Yes. No, that's not what you're affirming.
If I say, I completely filled out my food log, would you affirm or reflect?
On that, I would probably affirm that. And say, wow, you took time out all week to fill out your food. What great information you provided me. Because it's an effort. It's kind of a pain to fill out a food log all day, right? Or especially if you're a mom and you're trying to do it for your family and you're thinking about everybody's snacks and lunches you packed and what you're having for dinner. So that I would affirm.
Okay.
What about you, Dr. Dan? Does that seem reasonable?
I think so.
Okay.
Because I think just in that case, reflective. So you filled out your food log. Doesn't quite
did, right? Yes. Yes.
But yeah, something that's a little more.
Now, an example where you could reflect with that is where, say she says, it was really challenging and I only got 4 days back. And so then you could say, so I hear this food log on the day-to-day is pretty challenging. And there you're reflecting back.
Okay.
Does that make sense?
And an affirmation would be like, you did 4 days.
Right.
Okay.
Yes.
Gotcha. Thank you.
Now please do the other 3.
That food log is really hard to keep on top of, isn't it?
There you go.
Okay.
See now, and Dan can do really, really expanded reflections because he gets to practice a lot.
But wasn't that an affirmation?
Well, it's kind of
It's both, actually.
That's what- yes,
you've
that would
listened
be
to what they
both.
said,
Yes.
and you affirmed.
The stress of
Yeah.
it. So that's a very skilled practitioner that could do both in one
Right.
succinct statement.
Okay, thank you.
I go back to this a lot, and I think this is just simple social work school reminders. You know, you think so much in social work school about how to communicate, and using these not only in the motivational interviewing style, but just in trying to have an open and meaningful conversation with the patient or client. So no buts. The word but can negate all that comes before it. I'm sorry, but. You lost 5 pounds, but your blood pressure is still. I mean, do you see how that can be interpreted? Like the first part is lost, that I lost 5 pounds. And what you really want to tell me is that it's not okay that my blood pressure's over here. So if you could say, and you lost 5 pounds and I noticed that your blood pressure, how are you doing with your medicine? It just kind of changes the dynamics. And that,
Yeah, I just wonder if you should separate those two things.
well,
So, because really acknowledging the weight loss
is a big deal.
as a
huh?
big thing, and spend a couple of seconds on that, and then say, now let's talk about your blood pressure,
Yes.
or something like
Yes.
that.
I mean, that would be even a better idea. I'm just trying to come
Yeah.
up with things on the fly. The one that gets me is the I'm sorry, but.
I'm
I'm really sorry I hurt your feelings, but. It's like, well, are you sorry or are you still hung up on the thing that, you know? And then the whys. The word why can imply a judgment. Now, this is not to say you don't ever use why. But when we're talking with families or, adolescents, things that make us a little uncomfortable, we can often go quickly to why. Why haven't you quit eating fast food? Why did you go to your friend's house after school and smoke marijuana? I mean, I don't know. I'm just coming up with these on the fly. That sounds like you're judging them for doing that thing. Why would you do that? Whereas if we could say, so what about going to your friend's house after school and sharing that cigarette or whatever? Do you like? Do you enjoy? Meets a need of yours. Let's talk about that. And shifting from why do you do it to what is it about the behavior can give us more information at an angle to get to the problem and maybe negotiate a change or a goal.
So instead of saying, this might be a little loose, so let's say, I really need to have that evening glass of wine.
What does that glass of wine help you with?
So was it better to, so that's a why statement, but it's not an accusation why. But so
Right.
should I say, tell me why that glass of wine, wait, see I said why in there. Tell me more about the importance of that glass of wine. I guess you don't have to avoid the why.
Right.
You just
It's
have to avoid the
maybe where-
concreteness of it.
Yes, and maybe where it falls in the sentence. Because, I mean, starting with why sounds different than the example you just gave where you put it somewhere else in the sentence. What do you think about that? Because we talked about this before, right? The buts and whys and...
Yeah, I think you made the good point that it implies judgment. I think that you made a good point about what is it? Maybe ask, how come?
Mm-hmm.
But that can sound like why. So I think your what is it is a good one.
Okay.
Or just tell me more about that.
Yeah.
Mhm.
Yeah.
Okay.
Tell me more about that. I would like to understand. And then be unafraid to admit that you were wrong or off target or in left field and just say, you know what, I'm sorry, I got that wrong, what we were just talking about, and I would like to start over. And then just start over.
Do over.
A do-over. And you could even say, I'm sorry, I need a do-over. And how people will appreciate that, okay, I realize that whatever I said maybe didn't sit well with you. And now I've lost you in the conversation, and I just want to start over because it's really important to me to connect or engage with you and work out a health plan. Health behavior change plan. And that's all I have to say about that today.
Well, thank you, Carole.
So I would like to take roll call again. So not again, but if you have not announced your arrival or your participation in the session, please do so now so we can get you credit.
My name is Pat Yorman, Yorman, and I'm joining late. I apologize.
That's okay.
And my name is Margaret Dugan, Duggan.
And then my name is Marnie Nixon, and I was about 8 minutes late.
That's okay. And Marty,
It's hard.
Sorry about that, I tried.
It's A-okay.
This is Rosanna Trujillo.
Hi, welcome.
Hi. I was about 5 to 6 minutes late. Sorry, but I had a client.
That's okay. What made you sign on? No, let's not to sorry am I. No, thank you for coming on.
So, do you have any more games?
Well, I have lots of games, but not with me here right now.
So I do apologize for those of you who signed on late, but we certainly understand that. Oh, I said but. And
we certainly
unfortunately, Carole just completed her MI didactic, but I would like to know if there are any questions from the audience specifically about motivational interviewing or this lecture, and then we can see if there are questions regarding other items related to childhood overweight and obesity.
This is Pat. I do have a question. I know you're giving the motivational interviewing again at another time. Would I be allowed, since I got so late today, would I be allowed to sign on for that second presentation?
So that you would be allowed. Unfortunately, that was this morning. However, she can listen to it on the webinar or something.
Yeah, we do record the sessions, not the case consultations, but the sessions themselves. So that will be the one from this morning, and the one that you're attending now will be up sometime early next week, most likely.
Okay, and then how do I access that?
Go to our website, that's envisionnm.org, and where you register. But instead of going to the calendar, go to the videos page, and it's listed by clinic. So the PNT was this morning, and it'll be the first one in line there, and COMM-TC will be below that, or above that, actually.
Okay, very good. Then I think I'll sign off now and then do the listen to the recorded one. Thank you.
Okay, thank you for coming on, and we look forward to you coming back.
Yes, thank you. Bye-bye.
Bye. Any other comments regarding motivational interviewing for today?
Trying to turn it on. So, Carole, I wanted to just play the devil's advocate a little bit since I'm an old subspecialist. This is Beth Goins. So, when I go to my own doctor sometimes, I see that doctor as the expert I go to, and I just want to hear all of their recommendations, and then I want to be able to pick and choose which ones I I'll choose to follow, but I do want to hear all those. So I guess my one concern when we talk and when I try to think about how I would use motivational interviewing, it's kind of like when we're in med school and, the lecture. I like the lecture to bring it all to me right there, and then later I can go on my own time and think about it. So I guess my only concern is I don't want to overwhelm the patient with information, but I want to make sure it's all there for them to consider even later.
Right. And so, that's where you do that little bit of negotiation. And you would say, Dr. Goins, I have 3 really important things I need you to know. or I would like to talk to you about. And then you could just listen, but you kind of set them up to hear that you've got a lot of information for them. Is that answering your question? I mean, is that like because I think you have to make room.
Yeah, I think that it's just, you talk about what our role is, right? And so I think you say it's not our role to fix this this conflict for them, but I do think it's our role to bring them our expertise.
Yes.
And so I guess sometimes when I'm listening to just the whole debate about obesity and stuff, one of the things that I struggle with is if I have a child with congenital heart disease, I give them all the facts, but we've put this health problem of obesity in this sort of more emotional standpoint that makes it hard for us to talk about it. And I think that's one of the problems,
Yes.
It's like we're afraid to give them the facts, and then they can choose to follow our advice or not, but they need those facts to, as intelligent adults, if they're adults, make a decision on their own. So
Yes.
just bringing it to them shouldn't be offensive.
Let me see if this helps, because obviously, there are some things that just have to get done.
Correct.
But let's say that you have a child with congenital heart disease and they have left-sided failure, and their mom buys them a big old bag of chili hot red Cheetos every day, and their heart failure is getting worse. And you told her the last time that that's not a good thing to do because of the salt content, but it's still happening. And so that might be an opportunity to start kind of seeing if she's resistant or is ready to change a little bit, and the possibilities of how to move that forward.
Well, yes, but I would also say that
You said but.
So I'm not trying to negate what Dr. Conley just said. So let me add, and I think there are times, even as an MI person, that you have to say the thing straight out.
Right.
And there's no room for softening it. There's no room for I'm going to negotiate it. I need you to know that this thing that you're doing is contributing, making things worse, however you need to say it, that there are very appropriate times that you do that.
Well,
who does
what
a
I
really
do,
good...
just because you used a good example, Catherine, because, for example, I have children who have single ventricles. They crave salt, but they shouldn't have it. And I'm lucky because I see the same patients over and over, so we've developed a relationship. But I find that if I just explain to them that the way their heart's built makes them crave salt more, right there, just not saying you're a bad person because you're eating salt, but explaining to them why they crave the salt, yes. I think that actually helps them to understand not the kid being bad, not the mom being bad, but there's this craving they have to deal with. So, but I don't hesitate to tell them that, yeah, you got to get down on the salt, but this is why you want it so much, I guess.
Yeah,
Same thing with that.
So could you then move that into, so let's have a discussion about how we might negotiate or change your salt eating habits.
Yes.
And then give it to them. So those kind of tidbits, but if you've got to be on this medication, you've got to be on this medication. And if they're not taking it, then you got to start using your skills to try to get them to do it.
Yes.
Yeah, we have it easier than you adult doctors because the parents generally do want to do what's good for their kids, I think.
Sometimes.
If they understand it.
Yes. No, that's like what I said at the beginning about it not being a panacea for everything. And there are times where you just have to say the thing you need to say as a healthcare specialist provider. Thank you.
Right. You can't really say, what do you think about me intubating you right now? Let's talk about it. On a scale of 1 to 10. 0 to 10.
0 to 10.
So, yeah. And it's not for every single part of every visit either.
Correct.
It's more around things that you would like them to think about changing.
Challenges. Yes. And changes. Yes.
Well, thank you so much. I have to run and get this.
All right.
All right. Good luck. Other questions about that and/or anything related to childhood overweight and obesity from the audience? I don't know what our next session is. Our next session is scheduled for May the 3rd, and I cannot remember the didactic.
Well, it's me, so it's using technology to intervene in obesity. So,
Okay, don't sound so excited.
Well,
It's
I
Kevin.
haven't started on it yet. So.
That's okay. This is going to be exciting because this is where it's at, especially at the school-based health centers.
Yes.
And we've got to use technology to really help these kids, to reach them, and to make it more fun. All right. Well, I'm excited now. So I'll just pause to see if there's any final questions. I think that's a no. So we'll go ahead and close down today because, again, we didn't have any formal cases. But please, please, please bring cases. That's how we get our funding and keep these programs alive. Now I feel like I'm doing a fundraising for for COMM-TC. Anyway, have a great weekend. Exercise, follow portion control.
Thank you.
Thank you.
Bye-bye.